Good morning, everyone. Good afternoon or good evening, whenever you're hearing this. Welcome back to PodBites, where we break down complex medical topics into bite sized pieces, perfect for your commute, coffee break, or whenever curiosity calls. I'm Habiba, your host, and today I'm joined by.
Hayaa Elsherif. Today's episode is all about constipation and laxatives.
Yep, constipation is actually pretty common.
Yeah, it is. Constipation affects 15% of adults and up to 30% of the elderly. It's a common reason for seeking medical attention and is common in women. Unfortunately, it's often dismissed by doctors as a minor symptom.
But it's definitely not minor for patients.
Not at all. Constipation is a source of considerable anxiety and disability, often associated with general malaise.
I know we've all experienced constipation before, not that I'd ever admit it, but is there a specific criteria or medical definition?
Yeah, it's usually defined based on bowel movement frequency, specifically less than 3 bowel movements per week.
Oh, okay. Patients usually worry more about the symptoms though, like bloating and all that.
Exactly. They usually complain of straining, hard stools, incomplete evacuation, feeling the urge but being unable to go, spending excessive time on the toilet, and having abdominal bloating and discomfort. In fact, some studies show that patients mostly complained of these symptoms rather than just infrequent stool. So, constipation clearly means much more than stool frequency.
It's such a vague diagnosis, and maybe anything from symptoms to frequency. We use a specific criteria for diagnosis, and that is the Rome 4 diagnostic criteria for chronic constipation. Let's go through that.
To diagnose chronic constipation, patients must have at least two of the following things that we're going to talk about occurring in more than 25% of defecations. These things are training, lumpy or hard stools, which are Bristol types 1 and 2, sensation of incomplete evacuation, sensation of anorectal obstruction, manual maneuvers to facilitate bowel movement, fewer than 3 bowel movements per week.
Remember, they should have at least two of those things for more than 25% of defecations.
Those are the main things, but you should also keep in mind that they wouldn't have frequent loose stools if they don't use laxatives. And they must also not meet the criteria for IBS.
For how long should they have all these symptoms in order to meet the criteria?
Symptoms must be present for the last 3 consecutive months and must have originally started at least 6 months before the time of the diagnosis.
You said something about lumpy or hard stools being Bristol types 1 and 2. What was that again?
The Bristol Stool Chart classifies stool into 7 types. Types 1 and 2 are those hard, pellet like stools that have slow transit and low water content, which you would imagine if you think of constipation. Types 3 and 4 are your normal happy stools. Types 5 to 7 are progressively looser stools with faster transit and high water content, falling more in the diarrhea category.
Types 3 and 4, happy stools? Okay, let's focus on this. We've defined constipation, talked about all those diagnostic criteria. Let's dive deeper into its pathophysiology and try to understand why someone gets constipated in the first place.
Bowel innervation plays a huge role.
What's normal innervation like?
Proximal colonic motility and peristalsis are involuntary, while the actual act of conscious defecation is voluntary. This is all under the control of the autonomic nervous system.
So if someone has autonomic dysfunction, it alters their bowel movement.
Exactly. That's why slow transit constipation may be related to autonomic dysfunction. We also have some very important cells within the intestinal wall, which are called the interstitial cells of Cajal.
Wait, I just searched it up. It's Cajal.
Well, let's go with Cajal for
Okay.
simplicity. These cells are intestinal pacemaker cells, and they are crucial for regulating GI motility.
Okay, great. So it's autonomic nervous system and interstitial cells of Cajal. That's mainly the involuntary aspect. What about the mechanism of defecation itself, the part we can control?
Defecation starts when stool moves into the rectum and causes rectal distension. This stretching of the rectal wall activates stretch receptors, which then trigger the defecation reflex.
So once that reflex is triggered, what happens next?
The rectum and the sigmoid colon contract, increasing pressure inside the rectum. At the same time, the internal anal sphincter automatically relaxes. This part is involuntary and controlled by the autonomic nervous system.
But defecation isn't automatic at that point, right? It would be a chaos.
Exactly. Even though the reflex has started, the external anal sphincter and the puborectalis muscle are still under voluntary control. This gives the person a choice.
So, what happens if the person decides not to go?
If defecation is delayed, the external anal sphincter contracts, the puborectalis muscle tightens, and the anorectal angle becomes more acute, which prevents stool passage. Rectal peristalsis may even reverse temporarily.
Okay, perfect. Now, what if the person decides to go?
Then the opposite happens. The external anal sphincter relaxes, the pelvic floor descends, and the puborectalis muscle relaxes, straightening the anorectal angle. The person then performs the Valsalva maneuver, increasing intra-abdominal pressure, which helps expel stool.
Wow, sounds so medical. Now, can you repeat that in simple terms?
Sure thing, defecation is a coordinated process that requires rectal contraction, sphincter relaxation, pelvic floor coordination, and abdominal pressure. If any part of this coordination fails, constipation or evacuation disorders can occur.
Okay, clear. Now, what kind of patients usually get constipation?
Risk factors include advanced age, female gender, low fiber diet, low physical activity, or sometimes it may be due to an underlying abnormality.
Underlying abnormality, like?
There may be a structural abnormality, a functional one, or a systemic disease that just so happens to present with constipation.
Okay, let's start with the causes where there is no obvious structural problem.
In these cases, you try to look for any structural defects, but the colon appears normal. The issue is usually that the function of the bowel is impaired. This may be due to inadequate dietary fiber intake, functional constipation, and irritable bowel syndrome, which is usually accompanied by abdominal pain. Another important cause is idiopathic slow transit constipation, also known as colonic inertia, where stool moves abnormally slowly through the colon.
Okay, and if we have a structural defect, what could be some possible findings?
It could be anything that physically interferes with stool passage, so things like anal fissures, infections, or anal stenosis, as well as colon cancer or strictures, or it may be chronically enlarged idiopathic megarectum and megacolon, or a proximal megacolon, where the chronic dilation worsens the constipation.
Structure problems may also involve the structures that innervate the colon, aka the enteric nervous system.
Yes, there are disorders where the enteric nervous system is either absent or destroyed. So think of Hirschsprung disease, where it's absent, and Chagas disease, where there is destruction of the ganglion cells and the intestinal wall, leading to impaired motility.
So, Hirschsprung's disease is absent enteric nervous system. Chagas disease is destruction of the ganglion cells in the intestinal walls. Okay, now there may also be an issue with the muscle self, not just a local mass or abnormal innervation.
Exactly. Abnormal colonic muscle function in conditions like myopathies, dystrophia myotonica, and systemic sclerosis, all of which reduce the colon's ability to propel stool.
What if there's a problem with defecation rather than the colon itself?
That could definitely be the culprit. One major problem is pelvic floor dyssynergia, where the muscles responsible for defecation fail to relax appropriately during bowel movements.
So far, we've talked about functional causes, structural causes. We previously brushed over the fact that constipation may be a presentation of some other systematic condition or a condition that causes autonomic dysfunction.
Yes, neurological conditions that lead to autonomic dysfunction frequently presents with constipation. Those are diseases like diabetic autonomic neuropathy, damage to sacral parasympathetic outflow, spinal cord diseases, multiple sclerosis, and Parkinson's disease.
And what about the systemic diseases?
Systemic conditions, as you said, include metabolic disorders like hypothyroidism, hypercalcemia. There is also porphyria, which slows down gut motility, as well as pregnancy, which can contribute through both hormonal and mechanical effects.
Sometimes your bowel habits go crazy when you're stressed. Definitely not talking from experience.
Oh, yes, that's definitely another explanation. Psychological disorders such as depression, anorexia nervosa can lead to constipation. Although sometimes it may literally just be that the person is suppressing or denying their bowel habits. If they don't defecate when they get an urge, that could lead to constipation.
As medical students, we always memorize adverse effects of any drug is always constipation.
Definitely. So many drugs are associated with constipation. Some of those include opioids, iron, calcium, diuretics, antidepressants, antihistamines, anticholinergics, anticonvulsants, aluminum antacids, acetaminophen, aspirin, and NSAIDs.
Wow. Hard luck for the doctors. That's a lot of causes for constipation. You really have to dig deep to find the actual problem.
For sure, it can be anything in the body, from functional motility disorders to structural obstruction, neuromuscular dysfunction, metabolic disease, behavioral factors, or even medication side effects. That's why a structured evaluation is essential.
Then how can we reach a diagnosis in a structured thought process? I feel like it would be quite easy to get lost.
We can think of three major umbrellas: poor intake of water or fiber, pump failure, aka loss of peristalsis, or finally, outlet problems, and failure of sphincter relaxation. If you go from these broad categories and narrow it down slowly, you won't miss a differential.
So we organize our train of thoughts. Now we need to actually examine the patient and then proceed with labs and imaging.
It's very important to perform thorough history taking, physical examination, and rectal examination.
Anything specific we should ask about in our history?
You should look for anything related to all possible differentials that we discussed. You should also look out for any alarm features like unintentional weight loss, rectal bleeding, change in the caliber of stool, severe abdominal pain, or family history of colon cancer. In your physical examination, examine the abdomen for distension, hard feces in a palpable colon, or an inflammatory neoplastic mass.
Okay, history, done. Physical examination, done. Moving on to lab tests.
We do some basic labs, including CBC, ESR, calcium, TSH, glucose, and CTT. And if you were to find any alarming symptoms, you should definitely proceed with some imaging, specifically barium enema, CT of the abdomen, or colonoscopy.
Okay, if we're having a really hard time and we're still unsure, are there any advanced testing we can do?
If the constipation is so severe and not improving with laxatives, we could consider colonic transit study, MRI, difficography, anorectal manometry, or balloon expulsion test.
Colonic transit study is where we give the patient 24 rings and observe with an x-ray over the course of 5 days. If more than 20% of the rings remain, this is considered abnormal because it means the colon is not moving fast enough to get rid of the rings.
Spot on.
Okay, now we figure out the problem. How do we manage?
Management starts with treating any underlying cause and lifestyle modifications like increasing water and fiber intake. Then, if that doesn't help, we can proceed with pharmacological therapy, followed by biofeedback and, as a last resort, surgery, which is only reserved for selected refractory cases.
Biofeedback, I'll get back to that in a second. So we follow a stepwise process, starting with the least invasive options and progressing only if the symptoms persist. The focus is on identifying an underlying problem first, then choosing treatment accordingly. Now back to biofeedback. What was that again?
Biofeedback is a type of therapy that is recommended for constipation that is due to dyssynergic defecation or pelvic floor dysfunction, specifically failure of rectal evacuation. It uses sensors to provide feedback that trains patient to coordinate their abdominal muscles and relax the anal sphincter during defecation. It's like you're training the patient on proper defecation techniques. We usually consider biofeedback when laxatives and rectal evacuants have failed.
Okay, so worst case scenario, everything failed. Surgery is our last resort.
Surgery is reserved for severe refractory cases and is considered only after thorough evaluation and failure of conservative management. Some options include cecostomy, colectomy, sphincter division, pelvic floor repair, and stoma formation.
Okay, perfect. If you thought that's it for today's episode, you're wrong. Let's dig deeper into the pharmacological aspect of managing constipation. I'm sure you've all heard of laxatives, but I doubt everyone listening now knows all the different types. I personally don't.
Let's classify laxatives based on their mechanism of action. The categories include bulk laxatives, such as bran and psyllium, stimulant or irritant laxatives like castor oil, senna, and bisacodyl.
هي بجد بتتنطق كده؟
Anyway, osmotic laxatives, including magnesium hydroxide and polyethylene glycol, two softeners or emollients such as docusate, lubricants like glycerine suppositories and mineral oil, and a miscellaneous group including lactulose and lubiprostone.
Okay, now I know why I could never remember any of those. Anyways, what's the difference between a laxative and a purgative?
The distinction is based on the intensity of the action. Laxatives produce a soft, warm stool, and promote gentle bowel movements, whereas purgatives cause forceful evacuation of the bowel, often with watery stools.
Okay, let's start with the laxatives. Bulk laxatives, which was what? Bran and Celia?
Yes, bran or dietary fiber is the indigestible portion of plant cell walls. It increases stool bulk by absorbing water and swelling. This distension of the colonic wall stimulates propulsive contractions, promoting bowel movements.
Fun fact, fibers do not contribute to caloric intake because it isn't digested or absorbed, so you can have as much as you want. Bran seems pretty safe because it's just a fiber anyway.
Unfortunately, it does have some drawbacks, such as poor palatability, the fact that large amounts are required, and the fact that the full effect takes 3 to 4 days. Something important to remember with bran is that it does not soften the stool already present in the colon.
Okay, what about psyllium? It's another type of bulk laxatives.
Psyllium, also called spagula, comes from plants of the Plantago genus, which are mainly cultivated in northern India. It's used as a dietary fiber to relieve both constipation and diarrhea. Long term use may lower blood cholesterol.
Okay, so two in one, constipation and diarrhea. That sounds great. Now we're done with bulk laxatives. Let's get into the stimulant or irritant laxatives, which include castor oil, cinna, and pisacodine.
Stimulant laxatives act on the intestinal mucosa or nerve plexus, altering water and electrolyte secretion and directly stimulating peristalsis. They are described as the most powerful laxatives, but prolonged use can lead to drug dependence.
Okay, what about cinna?
Senna contains glycosides that are converted by colonic bacteria into sinusoids, A and B, the active compounds. It takes about 8 hours to work, so it's usually taken at bedtime. Adverse effects include colic and diarrhea. If used by nursing mothers, it can cause diarrhea in infants.
Okay, now moving on to the next type of laxatives, osmotic laxatives.
These include magnesium hydroxide, polyethylene glycol, or PEG for short. They exert osmotic pressure, retain water in the intestinal lumen, soften stools, and increase stool bulk, making bowel movements easier.
Anything with abbreviations probably sounds important. What was PEG again?
Polyethylene glycol. It's a first line osmotic laxative, especially for chronic constipation in the elderly, due to its safety and efficacy. It's also pretty useful when treating drug induced constipation.
We've talked about bulk laxatives, stimulant laxatives, and osmotic laxatives. The next type of laxatives is stool softeners, such as docusat.
Docusat works by emulsifying stools, allowing water to penetrate and produce softer feces, making passage easier.
Other than making the stool itself softer, we could make the area around it softer and more slippery.
For that, we use lubricants. Lubricants include glycerine, suppositories, and mineral oil. They coat stool and intestinal walls, preventing drying and making stools slippery. However, mineral oil can be difficult to contain by the anal sphincter and may actually leak out and be embarrassing for those patients. So it's best used for short term only.
Those are pretty much the major types of laxatives. I do have an important question though. When do we say a certain patient needs laxatives?
Indications of laxative use include short term relief of constipation, preventing straining, such as after myocardial infarction or hemorrhoids, or it may be used to prepare the bowel for diagnostic procedures, removal of ingested poisons, or as an adjunct in antihelminthic therapy to get rid of everything from the bowel as you're treating the infection.
Oh, I forgot. We have one special kind of laxatives for special cases, and that is.
Lactulose is a synthetic, non digestible disaccharide. It isn't absorbed in the small intestine, so it attracts water into the lumen, softening the stool. In the colon, bacteria metabolize it into lactic, formic, and acetic acid.
Okay, we said special kind of laxative used in special cases. So, of course, it has a special use. What was it?
Lactulose acidifies colonic contents, thus converting ammonia into ammonium, which is poorly absorbed. Ultimately, lactulose decreases the amount of ammonium in the blood. Since systemic ammonia level is the main culprit in hepatic encephalopathy, we can use lactulose to decrease ammonia and manage hepatic encephalopathy.
This sounds pretty important. You better keep it in mind. Now, these laxatives feel never ending, but we have one last type, and that is lopirostone, which is described as the most recent laxative.
It activates CIC2 chloride channels on intestinal epithelial cells, causing chloride secretion into the lumen. Sodium and water follow. increasing intestinal fluid and promoting stool transit. It's approved for chronic idiopathic constipation in both sexes and IBS-C in women. Common adverse effects include nausea and diarrhea.
Oh, nausea and diarrhea, not nausea and vomiting? Okay. Now, which laxative we mentioned can be administered rectally?
Rectal laxatives include glycerine and bisacodyl, given as suppositories, as well as soap solutions and magnesium sulfate, given as enemas.
Okay, got it. Now, when do we use rectal laxatives rather than oral?
We usually use rectal laxatives in patients with hepatic encephalopathy or patients going for GI surgery, radiologic procedures, colonoscopy, or before delivery.
Ugh, finally we're done. Before we wrap it up, let's quickly recap what we covered today. We started by defining constipation and highlighting how common it actually is, affecting a significant portion of adults and the elderly, and how patients often experience distressing symptoms beyond just infrequent bowel movements.
Then, we discussed the Rome 4 diagnostic criteria, emphasizing that chronic constipation requires at least two symptoms, like straining or hard stools, occurring in more than 25% of defecations. We also reviewed the Bristol Stool Chart to help categorize stool consistency and transit time.
Yep, and then we went over the pathophysiology of constipation, focusing on the role of autonomic innervation and the interstitial cells of Cajal in regulating bowel motility.
We also explained the mechanics of defecation, showing rectal distension triggers the defecation reflex and how coordinated relaxation of sphincters, pelvic floor muscles, and abdominal pressure are all required for normal stool passage.
Then we talked about risk factors and causes of constipation, including functional causes like low fiber intake, structural causes like fissures or tumors, neuromuscular and pelvic floor disorders, systemic diseases, psychological factors, which I totally denied, and medication side effects. I highly suggest you be able to list around 6 of those causes for your exam, but you didn't hear this from me.
Then, we discussed how to approach constipation clinically using structured history, physical and rectal examination, and diagnostic investigations ranging from basic labs to advanced testing like colonic transit studies, anorectal manometry, MRI difficography, and balloon expulsion test.
From there, we moved on to management, emphasizing a stepwise approach, starting with lifestyle modifications, treating underlying cause, then progressing to medications. Biofeedback therapy was for pelvic floor dysfunction and surgery as the last resort in refractory cases.
Finally, we reviewed the pharmacology of laxatives, classifying them into bulk forming agents, stimulant laxatives, osmotic laxatives, stool softeners, lubricants, and newer agents like lactulose and lubiprostone, while also discussing their mechanisms, indications, and adverse effects.
Don't get into those laxatives again. And then we wrapped it up by discussing special uses like lactulose for hepatic encephalopathy and the role of rectal laxatives in special clinical situations.
And we're done!
Thank you all for listening to today's episode of PodBites. Until next time.
Tune in, guys, for our next episodes.
عادي تبقوا تعملوا لي تاج في الستوري كل واحد أولوياته عادي أقول times 3 and 4 happy stools
أيوة ممكن تعملي كده
Please.
بعدين تعملي
مش هقول نكت So wait, that's contradicting what I said because I said you could have as much as you want.
عادي ما انت you're saying
إن
a
أنا
joke.
هبلة بقى وكده.
أيوة.
ماشي.
ايه ده؟ اسبغل هاتوا البتاع يا رب صبور.
الظروف لا تسمح. معلش يا جماعة عايش في الزور.
I like